Everyone, respected Professor Kato, Dr. Liu in his absence, all the speakers, my dear friends. This is the first webinar organized by the Young Surgical Nurses Forum of the Asian Congress of Neuroscience Nurses, Neurosurgical Nurses. And this webinar is going to be dealing with the exclusive care of patients undergoing endovascular procedures and the details of anatomical as well as all the procedure details of this thing. So I welcome all of you to this webinar. And now we move on to the first presentation by the nursing speaker, Ms. Meera. She is the nursing officer of Sri Chitra Tirunal Institute for Medical Sciences and Technology. It's a hospital of national importance of India. And it's the extreme end of South India. And she is working in the stroke ICU for more than 5 years and caring all the type of patients through the entire spectrum of care. So today we got an apt person. I welcome Ms. Meera, and it's time for you to present. And before that, I just call upon Professor Yoko Kato for the opening remarks. Off to you, ma'am.
Okay, thank you very much, Shani. We have just started of this CNN, especially the young nurse, focus on the young nurse webinar. So this is an educational platform. And I think today is we have very good endovascular neurosurgeon from Japan and also endovascular nurse from India. I think we are very much looking forward to their lectures, and hopefully I think many YNS or residents or young neuro nurse will join and enjoy their talk. All the best, all speakers. Thank you very much.
Thank you, ma'am. Ms. Meera can start your presentation.
So Shani, the first speaker will be Dr. Tanabe Sensei. Okay.
But I could not see him join.
Okay, I'm here.
Oh, sorry.
Tanabe Sensei is here. どうぞ。ちょっと待ってね。なんか、そうか、七井さんがいないんだ。じゃあ、舞さん、maybe
Yes,
Mai?
I will.
Can you introduce Tanabe Sensei, please?
Okay, I'd like to welcome our first speaker from Department of Neurosurgery, Fujita Health University Bandana Hospital, Nagoya, Japan, Dr. Jun Tanabe. So, could you start, Tanabe Sensei? Tanabe Sensei, お願いします。
はい。共有ができないん
Yeah,
で
I
す。
asked Meera to Meera.
Okay.
Actually, the first doctor speaker has joined, so could you stop sharing? Sorry for the inconvenience.
Okay.
共有できましたかね。
なんかミラーさんがね、画面共有しちゃってるんですよ
Okay,
ね。
she will stop sharing right now. Yeah.
OK。Can you see this slide?
Yes.
Okay. And thank you for the kind introduction. Today, I'm going to talk about endovascular treatment, which is all about using a catheter to treat blood vessel issues in the head and neck. This method has been getting more popular recently because it's less invasive and the new device have made it possible to treat more areas. We'll cover the anatomy, paradigm, architecture for using the femoral and radial arteries as approach route in this treatment. Overview of femoral artery approach. The femoral artery approach is a common technique for brain angiography and endovascular treatment. It's great because you can use a wide range of device and it's provides stable access. However, there are risks like subcutaneous hematoma and retroperitoneal hematoma. For some cases, like thoracic abdominal aortic aneurysm, we might need to use different approaches. Anatomical point of femoral arteries. It is crucial to understand the femoral artery anatomy to avoid complication at the puncture site. The ideal spot is the main trunk of, you can see here, main trunk of common femoral artery. Puncturing too high can cause retroperitoneal bleeding, while too low can lead to poor hemostasis due to the lack of the femoral head dorsally. Aim to puncture about 2-3 cm below the inguinal ligament. Using fluoroscopy, puncture about 1/3 to half below. This is the femoral head, 1/3 or half below the femoral head. Hemostasis of femoral artery. For hemostasis, we use either device or manual compression. Complications can include subcutaneous hematoma, pseudoaneurysm, and retroperitoneal hematoma. So proper hemostasis is vital. Retroperitoneal hematoma happen in about 0.5% of cases and can sometimes cause shock. Postoperative monitoring is crucial, especially since factors like age, obesity, hypertension, and anticoagulant therapy increase the risk of retroperitoneal hemorrhage. This is my experience for retroperitoneal hemorrhage. The patient was found to have shock vital when standing up tomorrow morning after surgery. She needed a blood transfusion. Overview of radial artery approach. The radial artery approach is becoming more popular because it's minimally invasive. Plus, patients don't need to rest in bed afterward, which is great for those who can tolerate prolonged bed rest. However, depending on the shape of the aortic arch, guiding the catheter into the left common carotid artery might be tricky. Anatomical point of radial artery. The average diameter of the radial arteries are about 3 mm in men and 2.75 mm in women. Ideally, the vessel should be at least 2 mm wide. Because it's narrower than the femoral artery, we should perform the puncture carefully and the ultrasound guidance. The distal radial artery here is getting attention lately because it's even less invasive. Hemostasis of radial artery. We use a compression hemostasis device for the radial artery like this. The device should be gradually reduced and removed within 4-6 hours. Continuous flow hemostasis is recommended to maintain blood flow and prevent radial arterial occlusion. Comparison of both approach. Each approach has its own pro and con. The femoral artery approach allowed the use of a wider range of device and offer more stability, but it requires postoperative bed rest. The radial artery approach is less invasive and more comfortable for patients with fewer postoperative complications, but it may have a limitation in the device use and needs careful evaluation of the aortic arch. Postoperative care for femoral artery approach, management of the puncture site, perform compression hemostasis to prevent hematoma formation. Watch for enlargement subcutaneous hematoma or pseudoaneurysm formation. Maintenance of rest. Device bed rest for a few hours post-operative to prevent movement. Offer support for patients anything back pain or discomfort. Risk management, lateral peritoneal bleeding, suspect lateral peritoneal bleeding if they are fluctuating vital sign or abdominal pain and respond quickly. Please note, lateral peritoneal bleeding may be related after the patient release from rest, like previous my case. Post-operative care radial artery approach, management of puncture site, use hemostasis device like the TR band, adjusting pressure gradually. Avoid excessive compression to prevent radial artery occlusion. Continuous flow hemostasis is very important. Prevention of arterial occlusion. Stick to the appropriate compression time to prevent occlusion. Monitor the fingertips for color and temperature change to check for blood flow disturbance. Patient activity. Encourage early mobilization and provide support as needed. No required bed rest. Promote patient comfort and recovery. So last slide, take-home message. To wrap things up, successful endovascular treatment depends on choosing the right approach and providing through postoperative care. Understanding the characteristics of each approach and taking good care of the patient can prevent complication and help them recover faster. I hope you can use what you've learned today to improve your clinical practice. Thank you very much for listening.
Okay. Thank you very much for interesting presentation. 田辺先生、ありがとうございました。Thank you so much. And the next speaker is...
ちょっと待って。Any question from the audience? Maybe I think Ayak from Nigeria. You have some comment or question?
No, Prof. Not now. Not now, Prof.
No, not now.
No,
Maybe-
yes.
Or maybe Hans.
Maybe later.
Hans.
Thank you, Prof.
No.
Yeah, I have the questions.
Please.
Oh, yes.
Go ahead.
Thank you, Prof. June Tabe, for very comprehensive presentation.
Please
have
introduce
questions.
yourself.
My name is Han. I come from Vietnam. And I have the questions for patient after they have the endovascular treatment in the radio arterial. So how long we should leave the compression for patient? Because in Vietnam, for patient with a femoral puncture, we should to leave it at least 6 hours. So for the radio artery, so how long we should leave the compression for that? Thank you.
Thank you for your question. In my hospital, there are artery compression about 4 or 6 hours.
4 or 6 hours, yes.
Yeah.
So the patient need to rest totally, I mean, not move their hand during that time, right?
ちょっとごめんなさい。なんて言ってました。
多分その圧迫してる間は動けないのかって聞いてるんだけど。
あ
とそれからこれは
はい
人海作戦じゃなくてそういうなんかあれで止血のあれで止めてんだよね。
そうですね
それ分。かってないかもしれない。手で押さえてんのかな。
We use the compression device like a TR band or do you know TR band? This is air compression for radial artery. Radial artery compression is not needed to bed rest for the patient.
Yes. So, they should not move their hand during that time, right?
そうそうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう。そうそうそう
Hold the hand.
Hand.
So-
I mean, they should
So-
keep their hand in place, right?
その間は手を
During
動か
that
してはい
time.
けないのですかって聞いてると思う。
No problem.
No.
Yeah, the patient can 動かすことできます。
Can I
So they can move
supplement?
their hand, yes.
Can
They-
I supplement? Actually, these patients with the radial band can walk or whatever activities they can do. But if there are underlying restrictions for his mobilization, that has to be followed.
I
That's
guess.
the thing. Otherwise, with simple radial band and after the simple procedures, they can walk around the bed. That's all. But they can bend the arm, but they are not need to give excessive pressure to the hand. That's all. And as doctor said, we have to keep it for 4 to 6 hours, and gradually they will remove the air. Through a syringe, we can gradually remove the air until the band is removed. Like that, it is for.
Yes.
So all on a sudden, we are not supposed to remove the entire air. Like
Yes.
that. Usually, after applying the band, they will instill or infuse air into the band, so that the tight pressure will come. So while removing, after 4 to 6 hours, slowly 5 ml like air will be withdrawn until completely over, and then the band can be removed. That is how it's followed.
Yes. Okay.
So,
Thank you.
Can I have a question to Tanabe Sensei? Shani, is okay?
Yes, ma'am.
Tanabe Sensei, how you can find the radial artery? Is it very easy to find the radial artery for puncture?
I think sometimes it's difficult to puncture the radial artery, but we usually use ultrasonography for puncture the radial artery. If we use ultrasonography, it is easy to puncture the radial artery, I think.
So what's the difference with the peripheral radial artery and the radial artery itself?
Distal radial artery.
Yes, distal.
Yes. Distal radial artery is reduce the radial artery occlusion compared to conventional radial artery, and patient comfortability is more comfortable distal radial artery.
Okay. ありがとうございました。Jennyさん
Miss Mai can continue.
Okay. The next speaker is okay. The next speaker is Senior Assistant Professor in Department of Neurosurgery, Fujita Health University Bandon Hospital, Nagoya, Japan, Dr. Kenichi Haraguchi. So, could you start your presentation, Haraguchi-sensei?
Okay, nice to meet you, everyone. I'm Kenichi Haraguchi, working with Dr. Kato since the last April. So I'm talking about the acute treatment of acute ischemic stroke, especially about mechanical thrombectomy. Okay, can you see this slide?
Yes.
Okay. So firstly, this is the representative case. So this 80-year-old female was carried to our department, emergency department, because of her disturbance of consciousness on the left hemisphere. So at first, she couldn't raise her left hand, left legs, but after treatment, the next day, she can her hemiparesis recovered almost completely. So what we did, how we treated her. This is mechanical thrombectomy. So this is the policy of this treatment. The time between the vessel occlusion and the completion of infarction is about 1 hour to 24 hours. So if we can reperfuse this occluded vessel, we can save the brain tissues. So how we can reperfuse the vessel? So many doctors thought about the way of reperfusion. At first, this is the historical way of the reperfusion, crush of the thrombus. Of course, however, this way can migrate the debris to the distal side, and other infarction will be made. And the second, we can think about dilation using the balloon catheter, but this has of course the risk of the remaining of the thrombus, and also the occlusion can be occurred. And this 3, 4, 5, this 3 way is a current way of the reperfusion. The first, dissolution of the thrombus. As you know, the 𝒂𝒓𝒂𝒂 is used since 2005 in Japan. And next, the aspiration catheter was made and used from the 2011. And lastly, the stent retriever is used for about 10 years. And so this is the 𝒂𝒓𝒂𝒂. As you know, the limitation of the time is the most important for usage of this drug. The time limitation is within 4.5 hours from onset, basically. But the effect is very limited for too large thrombus. So the manufacturing the company made a very good catheter to insert it into the peripheral part of the brain vessel. So this catheter reached to distal through tortuous artery. And however, it doesn't kinks, it doesn't collapse, and so this catheter has very thin wall and large inner diameter. So this can aspirate the large thrombus. And next, some doctor thought about the stent retriever. That of course the stent has been used for the coronary artery stenosis or stenosis of the artery. But this stent retriever is used for retrieval of the thrombus. So this cannot be detached. So this stent is connected to this wire, and it holds the thrombus. So using a guide wire, the stent was carried to the thrombus and pulling the wire, and we can retrieve the thrombus like this. So this is the first presentation case, the MCA, right? Middle cerebral artery occlusion case. This is the movie of the treatment I did. This is first controlled angiogram, the MCA, middle cerebral artery was occluded. Using the wire, we inserted the guiding catheter to the internal carotid artery, and using the guide wire, we inserted the micro catheter. This is the stent. The stent tip is here, and this is the proximal side of the stent. And we pull the stent with the guide wire, and we retrieve the thrombus from the occluded part. And the patient recovered very well. So in this technique, the reperfusion rate is very high. This is our data. The effective reperfusion rate was high as 83%. So this TICI grade is very important, commonly used in the thrombus retrieval therapy. So TICI-3, it means complete reperfusion. TICI-2B means more than half territory reperfusion of the occluded vessel. So TICI-1 is a very small reperfusion. 0 is completely occluded. So the indication of indication of mechanical thrombectomy. This is also important. So basically, this therapy is used for acute embolic occlusion. Of course, if this part is a chronic stenosis, we can almost we seldom retrieve the thrombus from here. So if this occlusion has a new thrombus, embolic thrombus, we can retrieve that. However, we cannot judge. We cannot judge whether this is acute or chronic occlusion, or this is atherosclerotic occlusion or embolic occlusion. So we have to consider this patient has atrial fibrillation or the severity of symptom. For example, if the patient have the conjugate deviation, almost of them is embolic occlusion, and the history or risk of atherosclerosis, for example, hypertension, diabetes is also important. So after that, the next important factor of the mechanical thrombectomy is time. Time is very important. Of course, the shorter time is very good. This is from the guideline from American Stroke Association. So basically, the less than 6 hours, it's the very good candidate for the mechanical thrombectomy. However, within 24 hours, we can consider the mechanical thrombectomy. And also, this is a guideline from SNIS. This is also the US guideline. So this paper says time is very important. And so they recommend the time between door to TPA. Door means in emergency room door. So we have to inject the 𝒕𝒓𝒆 within the 30 minutes from the patients coming. And after that, the dual puncture. Puncture means the start of the mechanical thrombectomy. So you have to check the image and inject the 𝒕𝒓𝒆 and carry the patient to the angio room within 60 minutes. And finally, the time to use for the mechanical thrombectomy is about 30 minutes. So within 90 minutes, we have to recanalize the occluded vessel. So this is the take-home message. So mechanical thrombectomy can rescue the acute ischemic stroke patient. So especially the embolic stroke, especially the patient who came faster to the hospital. And the top priority is time. Time shortening is very important. You have to recanalize within 90 minutes from patients coming to the emergency room. Thank you. That's all.
Thank you. Thank you, Haraguchi-sensei. Mai-san?
Thank you very much, Haraguchi-sensei. I can learn about the time is very important. So thank you. But does anyone have any question?
Can I ask? Sir, actually, in the event of if we did not get successful recanalization after RTPA infusion, can we go for mechanical thrombectomy?
ごめんなさい。もう一回、すいません。聞いてない。Sorry, can I say that again, please?
Yeah, so sir, actually, your presentation was very nice and very crispy.
Thank you.
I just want to ask one doubt. In the event of failed RTPA infusion, can we go for mechanical thrombectomy? That is after
failed
RTPA, in the sense successful recanalization could not be achieved after thrombolytic therapy. Can we go for? Is there any scope for bridging therapy?
So of course we inject the TPA, and after that we don't make sure whether the artery is opened, and TPA injection and the mechanical thrombectomy is performed simultaneously.
Okay.
No from nurse side?
待ってください。
No from nurse side, Chani?
What, ma'am?
No one's from nurse side? Any question or comment? So maybe because we have a two big giant of the Japanese endovascular neurosurgeon, so that you can invite.
Okay.
First, Izumi Sensei, please.
Hi. I'll make a comment, and Professor Haraguchi, long time to see.
Long time no see.
Yeah, I'm glad you're back in Nagoya.
Yeah, me too. Thank you very much.
And today, Professor Haraguchi introduced the development of the treatment for cerebral embolism, a serious disease, in an easy to understand and graphical way. The effect of thrombectomy is very dramatic, improving the quality of life of 1/3 of patients. He also explained the importance of shortening the time to start treatment and how to select patients who will benefit from the treatment. I hope that this treatment will become more widespread and more people will be able to maintain a meaning life. And finally, Professor Haraguchi, I congratulate you on the wonderful lecture. Thank you.
Thank you very much.
So one more question. Anyone can, both of you can answer. What about occluded carotid artery? Any endovascular treatment like carotid stenting? Are you practice there? Carotid artery stenting for carotid artery occlusion.
Yeah.
For the acute occlusion.
Yeah, not acute.
Yeah.
Yeah, chronic occlusion, unilateral carotid occlusion.
So you mean the patient who has both of intracranial occlusion and carotid occlusion?
Yeah, carotid occlusion, chronic long-standing carotid occlusion. If that is causing recurrent stroke, is there any treatment for endovascular treatment available there?
No, Haraguchi is asking at the neck or intracranial?
Neck, extracranial carotid occlusion.
So you are asking about the acute stage stenting?
Not acute.
Not acute.
Yeah. See, actually, in our hospital, once the acute ischemic stroke is over, patient will undergo thorough investigation, including carotid Doppler, in which we identify any major carotid occlusion. We advise the patient to go for carotid artery stenting. I'm asking about that intervention, if it's available there.
キャスもできるかっていうことを聞いてるんですかね。
まあそうでしょうね。
So yeah, of course, we can we can deploy the stent to the internal carotid artery, whether it's acute or chronic stage. If in some case of the acute intracranial artery occlusion, they have also carotid artery stenosis. In that case, we usually dilate the stenosed part of the internal carotid artery origin and insert the guiding catheter to the distal of the ICA and perform the mechanical thrombectomy. After that, we will consider the stent deployment for the carotid origin, internal carotid artery origin.
Is that okay?
Thank you.
Maybe we can invite Professor Nakahara Sensei.
Thank you.
Nakahara Sensei, comment on.
Yes, thank you very much for the very.
Tanabe Sensei no commentをお願いします。
Yes, regarding the lecture, the Professor Tanabe, a question was patient can walk quickly after the treatment, and the answer is yes. Just keep the hand like this. Even at the time of the distal radial artery, patient even can move the wrist. Just fix this position with a special band. So it's very easy for the patient to spend the time after the intervention. So very, very less invasive treatment if we can go from the distal radial artery. And the number of cases are quickly very much increasing in our institute. Probably more than 90%. We can do the intervention from the distal radial artery. So it's very nice. And regarding the talk of the Professor Haraguchi, as Professor Izumi mentioned, this treatment is not the treatment that we can do, but we have to do in most patients who has an indication for this mechanical thrombectomy. And the recanalization rate is more than 90% nowadays in our team. And of course, in Nagoya University, I believe that maybe nearly 100%. So the issue is not we can do, but we have to do quickly, quickly and as quick as possible. Maybe within 1 hour after the patient arrive to the hospital. So this is the first-line treatment, at least in Japan and in many Western countries. I don't know much about the condition of the country in countries who are attending this meeting, but please start the mechanical thrombectomy for your patients in your country.
Nakano-sensei, thank you
Thank
very
you.
much. So just I want to ask how we can reduce the time, how we can work up among the
Yes.
team.
Yeah, it's a very important question. Yeah, we have to make a very good team collaboration between administration officers and of course nurses and doctors and radiological techs. This collaboration is most important. I think much more important compared with the technique. So make a good team for the acute stroke is a very indispensable, I believe. Thank you.
Anyaku from Nigeria, please.
Yes, yeah. Thank you so much, Prof. Thank you, Prof. Thank you for all you do. Yeah, good evening all once more. Thank you, Professor Kenichi, for this presentation. I was impressed with the dramatic improvement of that 80-year-old woman with hemiplegia. Yeah, it was a very interesting case. I was looking at crushing, where we have a migration of the thrombus into the distal vessels, resulting in occlusion. So currently, do we still have reason to crush thrombus?
So your question is distal.
Sorry, sir. But do you still, because there is yes, ma'am. Yes, Prof. When we crush the thrombus, there is a possibility of migration of smaller thrombus into the distal vessels, resulting in occlusion. Well, this will be a complication of the crushing. All of the so, do we still have reason to crush thrombus now? Thrombus is still an option in thrombectomy.
So you mean
If it were, so how do we handle? So you don't understand me?
Yeah, we understood. Yes.
You're hearing me?
So you mean that can we select the thrombus crush for the final method?
Hear me? Oh, network.
細い血管までクラッシュできるかっていうことを聞いてると思うけど、末梢の。
クラッシュできるか。
要するにメカニカルに取れるかどうかってことも、その細いところの MC の末梢とかですね。
So basically, we treat the large vessel, but if the more peripheral artery is important part for that patient, for example, it flows into the motor area, we can retrieve the thrombus. Maybe the limitation, the most peripheral part is M3 in the middle cerebral artery, M3 portion, or if it is anterior cerebral artery, the A3 portion is the most distal part we can retrieve the thrombus.
Okay.
Thank you very much for the very nice question. Ikichiku, good morning. Can you hear me?
Yes, sir.
Can you
Yes, sir.
hear me?
Yes,
I
sir.
think that Dr. Haraguchi, Professor Haraguchi mentioned about the history of their mechanical thrombectomy. Currently, you don't have to crush. You don't have to crush the thrombus. Just catch the thrombus with a stent, but just aspirate. No need to crush.
Okay, interesting. Thank you, sir.
I think I could answer your question. Thank you.
Okay, sir. Thank you so much. I appreciate it.
先生、何かアフリカにメッセージを。
Yeah.
どこまで取れるんですかね。
Yeah, we catch the thrombs to distal to, for example, M2 branch and to using stent, but beyond the M2, distal M2 or M3 is difficult and dangerous to remove the thrombus, so we won't crush the thrombus. Okay.
Yeah. Okay, thank you. Thank you for your comments and adding to the topic. Now I invite Ms. Meera, a stroke nurse, who will be going to present the period procedural nursing management for these patients. After you, Meera.
Ma'am, is it visible? My slide is shared.
No.
Slideshow, please. Then start.
Ma'am, is it visible?
Yes, but put into slide presentation mode. Yes.
Okay, is it ready, ma'am?
I think your network is slow, that's why it's taking time. Yeah, it's okay, you can start.
Okay, is it visible?
Yes, please start.
Shall I? Okay. Good evening, everybody. Now I am going to speak about the peri-procedural nursing considerations in the endovascular treatment for stroke. That is, in mechanical thrombectomy, the pre and intra and the post-procedure nursing care I will be discussing. So the most important thing in the management of stroke is time. So time is brain. About 1.9 million neurons are dying each minute in an acute ischemic stroke patient. So the patient should be treated within 60 minutes, experience improved outcomes, including lower in-hospital mortality and reduced long-term disability. So the aim of our treatment is to restore the penumbra or to protect or reperfuse the penumbra. So here we can see the core area, that is the irreversibly injured tissue, and surrounding that the green area that shows the penumbra, that is the salvageable area. If the vessel is recanalized or reperfused, we can protect the penumbra. So our aim of doing mechanical thrombectomy is to protect the penumbra and to salvage that part of the brain. So to treat an acute ischemic stroke, we have to act quickly to restore the blood flow to the brain. And it may be done with the teamwork, that is the stroke team, and being the fast. So in the pre-hospital system, so as soon as we are recognizing the stroke warning signal, that is we know the warning signs, that is a loss of balance, blurred vision, face drooping, arm or leg weakness, speech difficulty. So if we are seeing a person with these problems, we have to immediately call to the nearest stroke helpline number, and we have to inform there, and we have to shift the patient to the hospital. So the stroke protocol for mechanical thrombectomy. So as soon as the patient reaches in ambulance to the door, while shifting to the emergency department itself, we have to take the patient history, and the vital signs is not checked, and the stroke team activation occurs. And the emergency department, the stroke neurologist and the stroke nurse arrives at the time of stroke team activation. And the stroke neurologist will collect the history and does the physical examination, and National Institute of Health stroke scale assessment is done. And the stroke nurse in the meantime arrives, and she comes with an acute stroke bag, and that contains the thrombolytic drug, the cannula, the BP apparatus, the glucometer, and the other drugs that is needed. And she inserts the 18-gauge cannula on the right antecubital fossa and collects the acute stroke worker blood samples. A large bore cannula is inserted because we have to inject dye during the CT angiogram. So we'll be inserting a large bore cannula, and the acute stroke worker blood samples, in that mainly the coagulation samples are collected, because sometimes the patient may be on anticoagulation therapy. And the vital signs, mainly the blood pressure and blood sugar, is noted. If the patient is in hypoglycemia, it can act as a stroke mimic. And it is very important to manage the blood pressure while managing the acute ischemic stroke. So after doing this, immediately we will be shifting the patient to the scanning department. So in the scanning department, while shifting to the scanning department, the stroke neurologist, the nurse, and the patient relatives accompanies the patient to the scanning department. We have to make sure that the patient relative is there with us in order to reduce the time delay in taking the consent or for doing the procedure. In order to reduce the time delay, the patient relative has to accompany us. And first we will be doing the plain CT or the non-contrast CT to exclude whether it is a hemorrhagic stroke or an ischemic stroke. And after excluding that, we will be doing the CT angiogram. If it is an ischemic stroke, we will be doing the CT angiogram or MR angiogram. And if the patient is coming to the hospital after 6 hours of onset of stroke, we will be doing the CT perfusion in order to find out the mismatch between the core and the penumbra. And after that only, we will be taking the patient for the mechanical thrombectomy. And as soon as the scan is done, the interpretation of the neuroimaging scan is done. And we will be deciding whether the patient is eligible for mechanical thrombectomy. So mechanical thrombectomy, it is a minimally invasive endovascular procedure to remove the blood clots from the large blood vessels in the brain. And it is done only in comprehensive stroke centers with neurointervention services and physicians with expertise in the procedure. And the most recently developed devices known as stent retrievers or stent drivers have shown the higher recanalization rate and better outcome. And the mainly used stent retrievers are the Saltair, Trevo, and the Penumbra. And the pre-procedure care, we have to make sure that the informed consent is taken before the procedure, as there are risks associated with the procedure. and see that the payment is explained to them as it is a costly procedure. And the benefit is time dependent. It is critical to treat the patient as soon as possible. And the eligible patients in the window period of 4.5 hours should receive intravenous thrombolytic therapy with alteplase without delay, even if the mechanical thrombectomy is being considered. That is the bridging therapy. And before taking the patient for the mechanical thrombectomy, we have to make sure that the systolic blood pressure is below 185/100 mm of Hg and the blood sugar is maintained below 180 mg/dL, and shift the patient to the DSA lab. So for the blood pressure management in the immediate time on the acute phase, we are usually using the drug 𝒏𝒊, that is an IV beta-adrenergic blocking agent, and it can be continued up to a dose of 300 mg. And if it is not controlled with that, we will be taking the nitroglycerin. And the patient with uncontrolled hypertension in spite of antihypertensive treatment is at high risk for intracerebral hemorrhage. So during the procedure, the interventional radiology nurse checks the vital signs, mainly the BP, and assess the level of consciousness. And the emergency drugs and intubation equipments are also kept ready. Even the procedure is done under local anesthesia. And keep a door to groin puncture less than 1 hour. And we have already seen that the success of the reperfusion depends on the thrombolysis in cerebral infraction scoring system. So here we can see the image of a patient who is undergoing thrombotherapy of the left MCA segment. And the first image, we can see the procedure going on. And the second, we can see that the thrombus is removed and it is successfully recanalized and reperfusion is attained. And after thrombectomy, the patient is immediately shifted to the stroke ICU. Then we have to assess the airway, breathing, and circulation. We have to strictly maintain the BP, and we have to check the vitals every 15 minutes for the first 2 hours and 30 minutes for the next 6 hours and 1 hour for 16 hours. And we had to assess for early signs of neurological deterioration. And the Glasgow Coma Scale Assessment, National Institute of Health Stroke Scale Assessment, and pupillary symmetry and reaction is also assessed regularly. And the blood sugar monitoring is done for patients with either hyperglycemia or hypoglycemia. And good hydration has to be maintained in order to maintain the cerebral perfusion. And the BP control. After the procedure, the optimal strategy for blood pressure management depends on the recanalization that is achieved during the procedure. So we have to maintain the BP of less than 140 millimeter of mercury for 24 hours if it is successful reperfusion. That is, if the sticky score is 2B or 3. And the permissive hypertension up to 180/105 mm of Hg is warranted if the TICI score is 1 or 2A to support the circulation to the penumbra. So in the monitoring, we have to mainly see that distal pulses are palpated. So whether if the patient is developing any vasospasm or any perforation, vessel perforation, and the puncture site is examined regularly to see for any bleeding or hematoma. And the sheath, if it is present, we have to flush with heparin flush every 30 minutes. And before removal of the sheath, we have to check the activated clotting time. And the lower limb is immobilized for 6 hours after the removal of the sheath. And the dressing removal of this sheath is removed after 24 hours. And the patient is kept nil per oral for 24 hours. And the CT scan is done on the next day morning or when indicated to rule out whether there is any hemorrhagic transformation. And the complications of the mechanical thrombectomy procedure are symptomatic intracerebral hemorrhage, which is the most severe complication, and damage to the vessels like arterial perforation, vessel dissection, vasospasm of the access vessel, and emboli to new vascular territories. Then reperfusion injury can occur, and the cerebral edema and increased intracranial pressure. So the points to remember are organized teamwork is needed to reduce door to puncture time, and good and effective nursing care is important for a good outcome. Patients eligible for thrombolysis should receive it even if endovascular treatment are considered. So how to reduce door to puncture time? Early stroke team activation, stroke nurse and physician reach emergency department at the same time, insert IV lines and collect blood samples while the physical assessment is being done, prior intimation regarding acute stroke in CT room, accompany patient for CT scan, and avoid unnecessary physical delays. So as conclusion, every minute that goes by is a minute that could change a patient's life forever. Every critical care nurse should remember the phrase, time is brain, when caring for a patient with a neurological emergency such as acute ischemic stroke. Thank you.
Thank you, Meera, for your excellent presentation.
Thank you, ma'am.
And now it is open for discussion. I ask Professor Nakahara for your comments.
Yes. I'm so impressed with the excellent lecture. She covered everything what we need for the patient care of the acute stroke patient. I mean, ischemic stroke patient. I think we have a very nice team in your institute. Congratulations for your fantastic presentation. Thank you.
So maybe we can ask Howard from Afghanistan.
Hello, thank you much. Konnichiwa, greeting from Afghanistan. I'm Dr. Pizat from Afghanistan. Great presentation and nice webinar. Thank you very much. Thank you.
Okay, thank you very much.
Professor Isumi?
Isumi has left, I think.
Okay.
Maybe Howard says it.
Professor Kenichi would like to add anything?
Comment?
Can I ask some questions? So, in your country or in your institution, do you perform the CT or MRI before the emborectomy, or MR only, CT only, or both?
So we are usually doing CT only before. After we will be first doing the plain CT, and in that we'll be ruling out whether it is hemorrhagic stroke or ischemic stroke. And if it is an ischemic stroke only, we'll be going for the CT angiogram.
So you don't perform MRI for acute stroke?
Yes, sir. We are not wasting time for MRI. During this time, we'll be immediately taking the patient to save the time.
So, but we are doing MRI scan in case of the doctors are not able to identify ischemic area, or at times when they are suspecting of posterior circulation stroke, brainstem stroke or something like that. Sometimes they go for MRI if plain CT is not conclusive.
Thank you very much.
Sensei?
Any other questions?
There is questions in the box. Yeah. This because the risk consideration in kind of MA after failed TPA.
Could you repeat the question?
Yeah, the question in the box, Q&A box.
Yeah, just see. Yeah. Can I address this? Actually, the question is, please discuss on the risk consideration in case of mechanical MA. What do you mean by MA? Maybe mechanical thrombectomy after failed RTPA. Can I ask this question to Professor Nakahara?
Yes, sure, we can do the mechanical thrombectomy even after the failed TP. It's of course possible, and we usually do mechanical thrombectomy even after the failed TPA. So TPA and go to the mechanical thrombectomy quickly. Do not hesitate. Go to mechanical. Am I answering correctly?
Just
Okay. So 𝒂𝒂 no more question?
maybe. I think
𝒂𝒂?
2 more participants raised a hand. If you are there,
Oh,
please type the questions on the chat box.
so I think maybe Dr. Nakahara Sensei is one of the top endovascular neurosurgeon in the world, not in the Japan. So we are very lucky to have him. Can you hear? So I think maybe Nakahara Sensei can tell us the future treatment of the stroke or future advancement of the endovascular area territory. Nakahara Sensei?
Thank you very much. Regarding the ischemic stroke, we may go more distal as the previous discussion to the M3, M4, and maybe P3, P4, far distal to the brain, and maybe another new devices will come, more efficient. Device can save the brain more quickly, more with a higher success rate. And regarding the hemorrhagic stroke, the main target is the subarachnoid hemorrhage, and to treat the brain aneurysm, the ruptured aneurysm in the acute phase. And we are getting new devices such as woven end ridge or some other new devices. Of course, the coil, of course, stent. And I think the availability of endovascular treatment for the hemorrhagic stroke is also increasing more and more in the near future. Thank you.
So, how do you treat of the vasospasm of the hemorrhage?
Yes. Maybe a mechanical, PTA, protein transluminal angioplasty for the spasm vessel. Maybe inject some drugs in a super-selective manner, but basically, rate of the vasospasm is decreasing due to the very nice medical treatment recently, maybe less than 5%. A symptomatic vasospasm rate is decreasing.
Any suggestion for African guy or Afghanistan? Was almost they treat a whole open surgery.
Oh, really?
Yes,
I think availability of
100%.
endovascular treatment depends on the devices, and in some countries still the cost of device is very high. So I can understand the situation in some countries, but I think a device cost should be decreased more and more.
Thank you so much. So maybe I think final comment from Haru Sensei, Tanabe Sensei, for all nurses, please.
Ma'am, we have a question in the chat box.
Okay, please.
It is written, how we will address the hemorrhage in case of mechanical thrombectomy while we are proceeding after RTPA therapy.
Haru Sensei?
それもう一回なんて言いました。
出血が起きたらどうしますかって TPA とか、スロンベクトミの後ですか。
So almost all of the case with intracranial hemorrhage can be treated conservatively, and if the hemorrhage is massive, like more than 3 or 4 centimeters of ICH, we have to evacuate by the craniotomy.
Oh, yeah, I think so. Mira, could you add in this? Do we give fresh frozen plasma or any antidote? Have you ever given that aprotrinin?
We are giving prothrombin and all. We are usually used for the patients who are having hemorrhage after thrombolytic therapy. And usually for the mechanical thrombectomy patients, we'll be usually having only hemorrhagic transformations will be usually occurring. And there won't be any bleeding cases are not occurring like that. And if it is occurring, if any bleed is coming, we'll be managing conservative, as Hausa told, we'll be managing conservative. We'll be going for craniotomy or craniectomy procedure will be done.
Thank you.
We'll be managing and we'll be managing the ICP. Cerebral edema and ICP management is done.
Okay, thank you. Thank you for your reply. Any other comments to add?
Sensei?
Thank you for the lecture today. It is important to understand the endovascular therapy for acute ischemic stroke for many professional co-medical. It is helpful to save the quality of life for patient. Thank you very much.
Yes, that's true. Shani?
Yeah, now, Prof, you can go on to have the closing remarks.
Okay. Thank you very much for everyone. I think now is endovascular treatment is mainstream in the neurosurgery. I think time is brain. I think we learned a lot from the three speakers. I appreciate it. Thanks so much.
Okay, so just an announcement, we'll be going to have more webinars on behalf of that young neurosurgical nurses. I welcome all of you to join for this. And today we had great physicians, endovascular therapists, and nice to have you, nice to attend your discussions and comments. And I thank all the speakers once again on behalf of YNN and all the participants. And thank you, Prof. Kato, for all the supports. And to Matron E also, she's busy with the conference, that's why, but she messaged me that she can't join because of that event. Thank you all. Thank you once again. Expecting your support again.
Okay. Thank you very much. See you next time.
Okay. Thank you, ma'am. Bye.
Bye. Bye.
Thank you.
Bye-bye.
Bye-bye.
See you. Bye-bye.
Yeah.